everybody. Welcome back to the living room. I want to start off by apologizing for the delay, not only to everyone in the room, but to everyone online. We were having some technical difficulties that the masters that be behind the scenes finally figured out. So welcome, welcome, welcome. As many of you know, because you received my emails, Dr. Malcolm DeCamp from Northwestern in Chicago is here to talk to us tonight about minimally invasive surgery. But before I give him a formal introduction, I do want to go back to around the room tonight. Due to the delay in programming, I'm going to ask that we just kind of be quick and concise so we can get through it, so we can jump right to all the really great things that we're going to talk about with Dr. DeCamp. So do we want to start over here? Can we start over here? Okay. Where's your mic? Sorry.
Rosemary. I was diagnosed with adenocarcinoma last June and had a lobectomy, a cycle of chemotherapy that didn't work, and now I'm undergoing molecular testing, looking at a clinical trial in immunotherapy and perhaps chemo again. So the search continues.
Tell them who you're going to go see tomorrow.
Oh, I'm going to go see Dr. Gandera at UC Davis. Although I had molecular testing and it was all negative, he thought this company, Response Genetics, had a superior system, and that even the NCI uses it. And I wanted to say to people who are sick with lung cancer that one thing that I've experienced that I think is really important is that you got to hang in there and just keep trucking, keep going, and if you don't have the energy to do it yourself, get yourself an advocate, because I'm pretty much a go-getter and I find it tough. But don't give up hope.
Don't give up. That's right.
Don't give up hope.
I'm Tina, and I was diagnosed with non-small cell adenocarcinoma 3 years and 4 months ago, and my last scan was clean as of February, so I'm good to go till the next one.
I'm Rick, and I'm Tina's husband, and it's been a crazy ride, but a good one.
Hi, I'm Nita Durand, and I was diagnosed as having non-small cell lung cancer in 2009. I went through a lot of chemotherapy, which didn't work at all, not anything. In fact, I had asked Dr. Wakely, I said, let's just throw everything you've got at it. And whatever it is, if it's tough, that's okay. Well, it was tough, and it didn't do a thing. So, along about January of the next year, they did look at the mutations. They were looking for mutations, and they started me in on Tarceva, and I was on Tarceva for 4.5 years. And then I also had, it was a stage 4 cancer. I had it in the bones in my hip. I had that radiated. I had the main tumor radiated, and it settled down, and then it started growing back. So at that point, we went sort of looking, but right about the same time, they looked at my brain, and they decided that I had leptomeningeal carcinomatosis, or that's it, I think. And so that's a lot more different than just lung cancer. It's lung cancer spreading to your brain. And we've looked and talked to several different physicians who are local and a little bit further away from here. But most of what they can do for you doesn't seem to be very good. We've talked about intrathecal, where they drill a hole in your skull and then they put in the chemotherapy, and since the chemotherapy didn't work too well the first time, we're not too enthusiastic about it working this time. And then another thing is you might have your whole brain radiated. And that does seem to kill a few brain cells, besides helping a bit. So right now I'm in a position of, waiting to see what happens next. I don't have many bad symptoms. All these things with the leptomeningeal thing. I don't have double vision. I'm almost asymptomatic, truly. I have a little bit of trouble being careful walking. My gait, as they say, is not quite as good as normal, but that's where I am right now. Oh, and because they didn't know what else to give me and they were kind of thinking about it, they decided, since I'd been doing well on Tarceva, that they would do pulsatile Tarceva, which means instead of taking 1 pill a day, you take 10 pills 1 day a week. And a lot of people take more than that, and nobody seems to know how bad the Tarceva is for you. And we think, since I went on the pulsatile Tarceva, it's been really strange. The leptomeningeal situation has settled down. It's not growing larger and larger. However, the lung cancer has started to grow again. So that's where I am right now.
I'm Esty Caldwell, and I had surgery. I had blanca alveola in 2003. I had my right lobe removed and the center one because it was small and attached to the top.
Esty, hold it a little closer.
Oh, okay. And so now they're just monitoring because I have, what do they call it, glass, all these spots. And so if they don't grow, I'll be okay. So I just get a CT scan once a year. Hope for the best.
Yes, I'm Athena, and about 15 months ago they found out I had stage 4 lung cancer. And then 3 months later, I got breast cancer, but I was fortunate the breast cancer was stage 1, but the lung cancer was stage 4. And they said that my lung cancer was so advanced that they couldn't operate, they couldn't give me Tarceva, they couldn't give me chemo or radiation. But all I've been on is 100 milligrams of Tarceva now for 15 months, and I've been doing great. I have no symptoms. Once in a while I get a little tired, but I have a lot of energy. I spent all day yesterday painting around the house and everything. And so my doctor about a month ago said, well, maybe it's not as bad as we thought because you don't have any symptoms, but I've got it all in my right lung. I've got it around my heart and my lymph nodes, so I'm doing good, but I don't know why.
Hi, I'm Neil. I was diagnosed 33 months ago with lung cancer, and right at the beginning I figured I was an athlete, so I had to have stage 1. And I went online, I looked at the VATS procedure that the doctor will talk about this evening, among many other things. Figured that I was a candidate for it. I said, okay, let's do it the next day. Next day they tell me, well, you have at least stage 4 and maybe more. So that was the end of watching the videos for YouTube and finding out about VATS procedures and taking out just that little area, because it was more than just that little area. So I did Tarceva for about 13 months, great reaction to it, but all good things. And then I went to IV chemo for another 6 months. That was poison, that was terrible. Decided, even while I was on the Tarceva, that I should be looking at clinical trials. So I found one that I thought was apropos to me. There was a Clovis trial that I spent all of last year on. And for most of it, very effective, very good for me in a lot of different ways because A, it was at Stanford, so it was close by. It was for my mutations, the EGFR plus the T790M. And even better, my doctor was running it. So that was the trifecta. When you can have everything so close, you don't have to worry about it. But like everything else, all good things must end. So in December, that was the end for me because there was no clinical reason for me to be on that trial anymore. So my superstar status with Clovis drug company ended at that point. I decided that I wanted to go back on Tarceva for a time to see how that would be. And it was okay, but not as good as the first time, and quickly showed that I shouldn't be on it, that I wasn't going to get the effect that I'd hoped for. So the next plan, which I had actually discussed with my doctor over 2 years ago, was afatinib and cetuximab, on which I have been now for the last 2 months. How's it working? Well, I feel okay. The truth will be April 2nd, CT MRI, the test of truth when we see what's going on inside. Over the course of the last year, I've had some CyberKnife treatments for brain metastases, and CyberKnife itself, for any who have not had it, is probably the most benign of any of the treatments, at least in my opinion, because all you do is lay down, put on the waterboarding mask, lay down there for 50 minutes, calm yourself down, the machine does all the work, you get up and leave. Well, that's how it's supposed to go. But I did have a few adverse effects. One most recently, as some of you know, I became blind at the beginning of February in a space of 36 hours. And that's attributable to, in my opinion, and my team of doctors' opinions, to some adverse effects of the CyberKnife, which caused cataract formation to go from pretty much a clear lens to an extremely hard, wide, and thick lens in the space of a couple of days. Fortunately, it has been correctable. Do I have perfect vision now? No, but it's better. I can drive, I can do things, I can see everybody here. The last meeting, I could barely make out anybody. And if some of you didn't talk and if I had not heard you before, I would not know who you are, even if you were standing in front of me. Now I can see you, so that's better. So that was an unpleasant surprise. We're going to write a little paper about it, see if other people have had the same type of thing there. But given the option of cutting into my head or CyberKnife, I'm ready for the next one anytime. I'll lie down, I'll get waterboarded again, make the new mask, and do the deal. In future episodes, I will give you an update on afatinib, which is a second-generation TKI. So the second generation after Tarceva, but before the Clovis drug, maybe, or the AstraZeneca trial drug, maybe. And the cetuximab, which is an IV infusion every other week. In my opinion and research, it's not a poison, which is what I call cisplatin and carboplatin and the others. To this point, in 2 months, no adverse effects, no diarrhea or any of the other things that I read about, but still waiting, and there's still hope.
Oh, we do? Well, I'm borrowing Neil's. I like Neil's. Hi, I'm Sally, and I'm the advocate for early detection. 10 years ago, I put myself into the International Early Lung Cancer Study, and for 5 years, just had small little nodules, and in the 5th year, one grew. And so I was hoping to have VATS, but I was told they wouldn't know till I got into surgery whether they could actually do that or not. And they weren't able to do it because of the location of the tumor. But I had my lower right lobe removed. I was very fortunate, thanks to being in that program. I was 1A when it was found. I am now celebrating my 5th year, the end of this month, of being free. I have other nodules that they're watching and going to make sure that they don't grow like that one did. But I feel very fortunate, and everybody who's at risk or a certain age, get a CAT scan.
Hi, everyone. My name's Elaine, and I was diagnosed in May of '08. And I have BAC, as they call it. And I can't even remember now what the other one was. But anyway, I was getting so sick. I was just sick all the time. And it wasn't just from my lung cancer. I had pinched nerves. I had 8 epidurals. And everything came back, and it was really horrible. So my dear Dr. Dormady put me on prednisone. And I'm telling you, within an hour, I felt like I did before. I mean, I was a new person. The pain went away in my back. And, of course, I've gained about 10 pounds. I'm eating about 6 times a day. But I then went into just the prednisone without any chemo. The doctors thought that I should, because my cancer was so slow growing, that I could go without any chemo. Well, I want you to know, I couldn't stand it. I was so worried without having anything preventative after this, it'll be 6 years in May. And so I told him, I said, I'm not happy with not having anything. And I'm just too nervous a person. You know, I'm nuts anyway. So anyway, I am on Avastin now, and we're negotiating with Tarceva. Now, I took Tarceva about 3 or 4 years ago, and I took it for about 9 months, and it just stopped working. So who knows what it will do now. The side effect I had acne so bad on my face, I wouldn't go out of the house for 2 weeks. And then, miraculously, it went away. Just went away. And I didn't have any more acne, so I continued to take it. And I'm certainly willing to try it again if we can ever get it straightened out. But I didn't feel good not treating it. It worried me. And, you know, when you don't feel positive about things, that's not good either. So here I am back on the chemo again, and I'm doing well. I've had 2 every other week of Avastin, and we haven't done the Tarceva yet. But I can remember when that first came out, boy, everybody thought that was the miracle drug, and apparently everybody's getting it. So we might as well try it again. But the only thing I have right now is fatigue. And I'm retired. I can go to bed. Dog and cat. You know, we sit and watch TV during the day, Dr. Phil. So anyway, thanks very much.
Hi, my name is Arash Golban. My wife was actually diagnosed back in December. She couldn't be here because she's managing the Girl Scout group, so Dylan and I came. She was diagnosed back in December. She was put in Tarceva right away. So far, she's reacted very well to Tarceva. She's back to work as of January, and she's pretty much back to doing her normal life. So far, very, very good.
My name's Melise Skelton, and I'm here because my father was diagnosed with lung cancer in December of 2009, and went through 3 months of daily radiation and CyberKnife because it had metastasized, and chemo, and unfortunately passed away in April of 2011. So I'm just getting involved because I have, unfortunately, another uncle and another aunt that have also passed away, and I think it's time that I put my efforts into making sure that I don't have any more family members, and no one else has any more family members that have to go through that.
My name is Robert Curry. I'm the husband of Kathy Curry. I wanted to come tonight to let people that may not know that my wife passed away the 17th of February. She had diagnosed with lung cancer and fought it for 2 years. And finally, in the last week, she came to peace with herself and passed away peacefully. She went through a myriad of things. We went to UC San Diego. We went to UC Davis. There's a lot of very excellent people out there that's working the issue, but we just need early detection to detect lung cancer early so that surgery is a possibility as opposed to detecting it at stage 4, which seems to be the majority of the cases. So she went through Tarceva, which worked magic, and that set the bar for any other medicines. Avastin didn't work at all. Chemo didn't work at all. They misread some of her biopsies to determine what the molecular makeup was, what the markers were. So it's really important that they do molecular marker testing early in the stage because there's a lot of targeted medicines that really work much better. Clovis is one of them, Tarceva is one of them, but if you're got the wrong markers, they don't do anything for you. So just she really appreciated all the support that the foundation provided, the information, the support from the members that came, and she really enjoyed coming here when she could. So I want to thank everybody for her. Thank you.
I'm sorry for your loss. And my name is Tao. I was diagnosed stage 3 16 months ago, non-small cell and adenocarcinoma. And I had a lobectomy, a radiation and chemo. And a few months ago, accidentally, my doctor did a biopsy for something else and found that I had a small nodule with cancer. So I had ALK mutation. So I am now on crizotinib, and I just had CT scan and MRI, and I will see my doctor soon tomorrow to see if the crizotinib work well. And thank you for coming, and hope that we'll find something soon to help alleviate our suffering.
I'm Michael. I'm with Tao, and we're as optimistic. So.
Yeah, there we go.
I just want to tell you, my name is Barbara, and I'm from Oregon, originally from the Bay Area, but came down to visit my grandkids and my grandson. And I want to tell you guys that I've been watching you online up in Oregon, and you have given me a wealth of information, and I want to thank your foundation for it. I also have lung cancer. I had a right lower lobectomy in October of 2012, and I'm glad to be here. And it's almost like I can't believe I'm in awe because I've been watching you for months online. So thank you for letting me come.
Does anybody else who is sitting along the wall want to talk? Terry?
Hi, my name is Terry Fry, and I'm here. My daughter was diagnosed in 2010. She was 32 with stage 4 adenocarcinoma, and initially it had gone into the pleural, but she thought she was going to be a candidate for the EPP operation, so we went back to Boston, and in the process of getting her lymph nodes tested, they found that it spread there, so that stopped that process, which I'm very glad for, due to the fact that I don't know whether she would have made through it or not. But she's went through Alimta, Avastin, and cisplatin for 6 rounds, then on Alimta and Avastin for many more rounds, and then just on Alimta. And then she had the one spot in her left side targeted radiation. And as of January, she's been on a chemo vacation for over a year now, and she has a scan on Thursday, and hopefully she can continue her chemo vacation. One side note is that she does do a lot of, she goes to acupuncture 3 times a week and takes a lot of supplements and Chinese herbs, which I really do believe has helped the situation.
Anyone else? Liz? No? Okay. Okay. Thank you, everybody. Were you going to say something? Oh. So I'm going to give you guys a little introduction on Dr. DeCamp, and then we're going to jump right into to tonight's topic. So Dr. DeCamp, as I said, is from Northwestern University in Chicago. He's the chief of the thoracic surgery division, professor in thoracic surgery and pulmonary medicine, with obviously a special interest in lung cancer. His research focuses on advanced lung disease, such as emphysema, lung transplantation, thoracic cancers. He's authored more than 100 peer-reviewed publications and 31 book chapters in print. He's a very highly sought-after speaker, so we're very happy that he came out here to be with us tonight, and has presented at more than 60 national and international seminars. So we are in absolute good hands tonight with Dr. DeCamp. He joined Northwestern as professor of surgery in December 2009 to develop multidisciplinary disease programs in thoracic oncology and a couple of other things, swallowing disorders, complex airway, minimally invasive surgery, and advanced lung disease. For more information, I think I attached the link in the email. If I did not, you can pick up, if you're interested in reading some of the publications, you can pick those up online. So tonight we're going to talk about minimally invasive thoracic surgery, different techniques, and where surgery falls in the lives of a lung cancer patient, from diagnosis, staging, and treatment. Welcome, Dr. DeCamp.
Thank you.
So to start off with, Dr. DeCamp, let's take sort of an overlying umbrella role, talking about what role thoracic surgery plays in the life of a lung cancer patient.
So listening to all of your stories around the room, the ratio is about right, unfortunately, right now. You know, I heard about 2 or 3 people here who had early stage disease, and the majority of you had either locally advanced or, unfortunately, stage 4 disease. And that's the national figures, not a surprise to anyone. Lung cancer is not a one-size-fits-all disease. And you know, the interesting part to me, the exciting part to me is the right way to take care of this disease is with multiple disciplines coming together around the patient, not you guys having to go seek out multiple different opinions of different modalities, but getting the relevant physicians together with the right skill sets. So there's 3 ways we attack cancer. We cut it out, we use medications, and we radiate it. So medical oncology, radiation oncology, surgical oncology. So I'm a surgical oncologist, and I think it's important to bring all those thought leaders together to look at your particular problem. So when I meet somebody with a new suspected or even a proven lung cancer, we got to look at the biology of the cancer and the physiology of the patient. What other medical problems do you bring to the table? Are you an athlete and you're in great health, or do you have other problems? Because those 2 things come together in the art of medicine to figure out what we can do and what we can't do. Can't do everything to everybody. We can talk a little later about earlier detection, which is the quickest way, in my opinion, to change the score in this disease. So right now, about 20% of lung cancers are diagnosed in stage 1, and the vast majority of those can be cured with 1 operation and no medications. Pain medicine for a few days. But in the National Lung Screening Trial, which was a big 50,000 patient trial that was done here in the United States of people at risk, heavy smokers, 30 pack years of exposure. So everyone understands what a pack year is. Pack a day for 1 year, 2 packs a day for 15 years. Active smokers or former smokers, but they were randomized. Half of them had just chest x-rays, half of them had low-dose CT scans. And there was a 20% reduction in lung cancer death in the people who had CT scans done. And that's by far and away the biggest advance in the survival of lung cancer in our lifetime, bigger than any chemotherapy that's come to bear. Why is that? Well, if you look at the stage of diagnosis in those CT detected cases, 65% of them were stage 1. So this is something that's happened in all of our lifetimes in breast cancer with mammography that's now embedded in primary care. And we still make major advances in the care of breast cancer, in advanced cases of breast cancer. But I don't think we take it for granted, but what we forget is that with early detection, there's a lot of women still alive and cancer-free because they were detected at an early stage and they had appropriate therapy. That's where we're just starting to head in lung cancer. If we can detect more of these stage 1 cancers and take them out, we can continue to investigate the advanced disease. We can continue to dissect apart adenocarcinoma. I heard a predominant, history of each of you around the room that have different types of adenocarcinoma. That's not one disease now, it's a family of diseases. Some of them are EGFR mutated, some of them are KRAS mutated, some of them are ALK mutated. We've now been able to figure out about 60% of the adenocarcinomas, we can define a specific driver mutation. We still have more work to do to find out the other 40%. And then a ton more work to do to come up with targeted drugs for each of those different mutations. So we're just in the infancy of that. So we have Tarceva, you heard a lot about. We have the second generation. We have drugs that are now active against the T790 mutation, which is the resistance to Tarceva. There's a lot of things that we can do to learn more about how to manage patients with stage 4 disease. But the first thing we ought to do is try to find them before they're stage 4. So that's why I think surgeons come into play, and surgeons need to be at a seat at the table, and surgeons need to do a better job of educating primary care physicians about the relevance of screening and the importance. There's a lot of debate going on in the government right now about whether low-dose CT screening is going to be approved. I think it will. The taxpayers, we all paid for this trial. The trial had a positive result, so Medicare is about to issue a coverage decision that we'll be able to get this paid for. Some of the private insurers are already coming down the pike paying for it. But that'll go a long way to helping shift the tide here. At the same time, we need to stimulate more research. You know, we spend 100 times more dollars per women who die of breast cancer than we do for folks dying of lung cancer at the federal level. So we need to not take money away from another disease, but advocate for more research. But the surgeon's role we've got an important role in early detection. We have an important role in staging that cancer, not just clinically based on scans, but pathologically by looking at lymph nodes. And then we play the dominant role in how to cure that early stage of disease. So if we don't have a seat at the table, if we don't get to meet you when you're diagnosed, then we're a silent voice. So I think we need to advocate for people to be cared for in an environment where you have input from all the major disciplines: surgical oncology, medical oncology, radiation oncology.
So, taking on what you just said, when is it appropriate for a patient to suggest that a surgeon be part of the equation? I mean, when you're looking at patients who are diagnosed at stage 4, whose docs maybe aren't even thinking that someone like you even needs to be notified, sure, let alone...
Well, we talked earlier offline, is there ever a role for surgery in stage 4 disease? You know, surgery and radiation are things that fix what you aim them at. So if I can fix a nodule in your lung, I can deal with a bleeding problem, I can deal with something that's obstructing something. So that is the symptomatic benefit that what I do takes care of. Same thing with radiation. And in stage 4 disease, if I don't think I can help you live longer and I have a less morbid way to get the result, then that's why we often resort to radiation. But my concern in hearing patients' stories is, how is it proven that you were stage 4? Was it I had a lung nodule biopsied, and then I had a PET scan and there were some other abnormalities, and they just assumed that was cancer? You can't assume everything on a PET scan's cancer. PET scan is a useful tool, it's a very powerful tool, but it's just a tool of metabolism. It's not a cancer tool. So there are inflammatory things, infectious things, things that'll light up on a PET scan that, in my opinion, we're obligated to prove are cancer before we just condemn someone to a systemic treatment without any concern for local therapy. We've also heard around the room 3, 4, 5, 6-year survival in stage 4 disease. When I started my medical career, that didn't happen in stage 4 lung cancer. You know, the median survival was less than a year. So we're starting to see what most of us in the field get excited about, is turning lung cancer, at least advanced stage lung cancer, into a chronic disease. If we start to change the natural history of that disease, then we need to start changing our thinking a little bit about, well, maybe in some of these situations where we've taken care of all the metastatic disease with erlotinib, or we've taken care of all the metastatic disease with crizotinib, but that primary starts to grow again, maybe we've eliminated all the ALK mutated cells there, and there's just a few recalcitrant KRAS cells that aren't going to respond to that. Maybe it's time to rethink taking those primary tumors out. And each of us in the field have sort of case reports and one-off situations to share with each other, but we need to begin to explore that across multiple centers to try to answer the question, is that the right strategy? But at an individual level, you don't want to know what's going to happen to 100 people. You want to know what's going to happen to you. So when we're face-to-face in the doctor-patient relationship, I think it pays to have a multidisciplinary team that's open-minded, that's willing to change the paradigm in specific situations. So when you're 5 years out from a diagnosis of stage 4, you don't go to the textbook and look that up. You know, that's a very individual patient and physician decision. And I think the more smart people you have around the table to help make those decisions, the better.
You know, taking that a little further, so you take, you know, anybody who has a stage 4, and it's been proven that it has gone distant, but the major mass may be in the right upper, right middle, wherever it happens to be, but it's identified. Why not take that one out and either using the VATS or some other procedure, knowing that, yes, there are some others, but if I can get a big one out of there, does that have, you know, palliative help? Is that worthwhile?
Great question. Very human, common sense kind of question. If you can't take all of it out, can't you take part of it out or most of it out? I really come down to, you know, pain and suffering. If my understanding and the multidisciplinary team's understanding of the natural history of this is that taking out that right upper lobe lung cancer isn't going to help you live longer, then I got to have a good reason for doing that. And if I do something, there's a finite risk to surgery. We can talk about VAT surgery, but the chance of dying from VAT surgery is not zero. It's not having your teeth cleaned. You know, I need to be really sure that it's safe and that it's going to be helpful. There are other tumor systems, lung cancer is not one of them. There are other tumor systems where renal cell cancer, for example, taking out the primary seems to make the patients respond better to systemic therapy. Why that works for kidney cancer and doesn't work that well for lung cancer, don't know. So when I look at you and meet with you face to face, if I don't think what I'm doing is going to help you, I have a hard time justifying you taking any risk. Even though it makes you psychologically feel better, if I don't think there's a real benefit there, then, you know, our oath is do no harm. And surgery creates a little bit of harm. Now, if you're in and out of the hospital in 3 days and you're off your pain medicine in 2 weeks, you can say perhaps no harm, no foul. But if I stub my toe and you end up with pneumonia and atrial fibrillation and on Coumadin and then have a stroke, and then you're not here to argue with me, but then your family's upset with me. That's not as good that's not doing the right thing for you. That's just doing something to you. So that's really how, when I get face to face with people, I think about, am I doing something for the patient or just to the patient?
So many people here.
Jim, we grab a mic, sorry.
Oh, I'm sorry. Okay. You don't need it. So many people here have been, their lives have been changed by having effective, Tarceva being effective in managing their lung cancer, some longer than others. Is there anything in the pipeline, in Tarceva's EGFR, anything in the pipeline that's going to be as transcendent as Tarceva in the foreseeable future? Perhaps a different mutation or a combination of mutations or whatever. So,
well, I'm a surgeon. I surely don't want you to get surgical advice from a medical oncologist. And my medical oncology colleagues are going to cringe. I mean, they shouldn't cringe, but I think Tarceva and then crizotinib were like the first drugs in this concept of molecular testing and finding a targeted agent, where we have an expectation that 90% of the patients that get the drug are going to respond. Whereas combination chemotherapy, I heard a lot of people say poison, it didn't work at all. Medical oncologists for years were okay with 50% response rates, 60% response rates. And that was a very hard concept to explain to patients who are used to, like, I got pneumonia, you get the right antibiotic, doc, 99.9% of the time I'm better. And chemotherapy just isn't that way. Fast forward into this era of molecular diagnosis where we understand adenocarcinoma is not one disease, it's a family of diseases. They all have that same name, but they're all governed by a specific driver mutation. So we think EGFR mutated adenocarcinoma, means it's EGFR positive and all the other cells are, there's no KRAS, there's nothing else going in there. Well, now we're finding out that after you respond for a year or two to Tarceva, and then we rebiopsy those things. This is one of the things I was going to encourage people to consider. When your tumor recurs, prove it. Because we need to understand the molecular basis of that recurrence, and is it the same or is it different? So a number of you who've had recurrences have this T790 mutation in the EGFR thing. So there's new drugs coming down the pike that are supposed to either get around that or ignore that problem and continue to work for the patient. But then there's other mutations that we're working on, and if we could ever, for example, come up with a drug against KRAS, because that's such a big chunk of patients, 30, 35%, 40% of patients. We know we can find the KRAS mutation, we just don't have a drug for it yet. So if we found a drug for that, that would be transcendent. We continue to unlock that pie chart of adenocarcinoma and come up with a drug for each of these. So there are some other drugs. There's drugs for MET. There's a bunch of other interesting drugs being developed. Not the area that you brought me here to talk about. There's some immunotherapy things coming down the pipe, ways to harness the immune system. So those are all very exciting. I still want to find all the cancers early and just take them out. That would be my preference.
When you do a surgical procedure, is there ever a chance in your mind or medically that doing the procedure causes the cancer to go somewhere else?
Great question. So when we learn the craft of surgery and surgical oncology, we were traditionally taught this no-touch technique where we try to control the blood vessels leading to and from the area of the tumor, whether you're taking out a colon cancer or something, before you manipulate the tumor. And there's been a lot of interesting studies trying to measure cancer cells floating around in the bloodstream during the middle of an operation. So we have to presume we're doing something. That's why surgery doesn't cure 100% of people, even for stage 1 disease. Stage 1, depends on how big the stage 1 tumor is, right? If you have a T1A tumor that's, under 3 centimeters, then the likelihood that we cured it if we do a good operation and take out plenty of lymph nodes and prove that it's stage 1, that's probably 80% likely that we've cured it. But that means 20% of the people, despite that, aren't going to be cured. This is what's happened in breast cancer. We've been able to find these early stage women with breast cancer and look at some of the biomarkers in the tumor and said, despite the fact this is early stage, this is a bad actor. And this is the woman that will benefit from more aggressive treatment even after surgery. We can get there in lung cancer too. Stage 2 lung cancer. We didn't talk to no one here, I don't think, had stage 2 lung cancer. That's a cancer in the lung and some lymph nodes involved, but the lymph nodes are still within the lung. So it's really hard to tell stage 1 from stage 2 until you take it out. Most of my career up until the last few years, people were thrilled. Oh, I don't need chemo. Yeah, but the outcome in stage 2 lung cancer is 50-50. And I'm not really happy about meeting you post-op and saying, hey, we're going to flip a coin about whether I've cured you or not. There ought to be something to do to make that better, which is why we typically will recommend adjuvant chemotherapy for patients who have stage 2 disease, because it improves the outcome, not 100%, but about 10%. So it takes 50% chance of beating the disease up to 60. So every time we touch a patient, there's a possibility that there can be a bad outcome. one of the reasons we advocate lobectomies versus lesser than that is that we're getting down to that drainage basin where the nodal disease can be, and we're a little further away from the tumor, so we're not manipulating the tumor during the operation. So we don't want to squeeze it. I don't want to squeeze the cells into the system. I want to get around it, get it out before anything bad happens like that.
Have you ever seen anybody that's taken Tarceva and then the tumor shrunk enough where you could go in and operate and take everything out?
Yes and no. In other words, I was sharing earlier with some of the staff situations where we've had such dramatic response and no other sites of disease that we've rethought the paradigm of, well, this is a stage 4 patient. I have one in my mind right now who had a 7 or 8 centimeter metastasis in her adrenal gland and a big right upper lobe lung cancer and a big right hilum full of disease when she presented, and you put her on Tarceva and she responded fantastically for 2 years, and it's like, now what do you do? She has this still a mass in her lung. Her adrenal looks normal. I looked at her lymph nodes by endoscopic ultrasound and by mediastinoscopy and didn't find any cancer in her lymph nodes, and I'm like, I don't think she'll respond to Tarceva forever, so do we think about doing something? So we took out her adrenal, and she had a little 3 millimeter focus of cancer in her adrenal that didn't have the EGFR mutation, had a KRAS mutation. Now that means did the cell develop? Is this a new thing, or is it just we had selected out all the EGFR positive cells and they were all dead? But I don't know the answer to that. We need more research to figure that out. So now she has no disease in her abdomen, no disease in her lymph nodes, so I took out her right upper lobe by VATS, by minimally invasive surgery, and that was all scar. There was no cancer there. Great news. Begs the question, did I help her? I don't know. I mean, psychologically, she's thrilled. But it's perplexing biology.
I don't know if I'm jumping the gun, and maybe Danielle was going to ask this later. We've mentioned VATS. For people watching, if you could explain to them what that is. And also, I have another part to this question. I don't know, do you do robotic surgery as well?
I don't, but my partner does, so I can address both.
Because I know I was very fortunate. I got to go visit the Da Vinci and be a part of this group for 3 days. And turned out we were all stage 1. I was the only local. They were from the East Coast, they were from the Midwest. And when I looked it up on the internet, there are very few doctors here that do it. So I wondered what your feelings were also with robotic surgery as opposed to regular surgery.
So real quick, before we go into like the different types of surgery, I just want to ask a couple of online questions that kind of go back to what we were just discussing. So one online question is, if a primary tumor in the lungs appears to be necrotic, would that qualify that patient potentially for surgery?
Sure. So tumors look on CT scan and PET scan different all the time. And some tumors are growing relatively quickly and they outgrow their blood supply, and the inside part of the tumor dies or is necrotic. I explain this to patients like, you got a jelly donut in there, okay? The donut part is the living cancer, the jelly is the dead stuff, but it's still growing. So that doesn't rule in or rule out anything. It's all, to me, it comes down to stage, lymph nodes. If you don't look at lymph nodes, everyone has stage 1 disease. So the fact that the primary tumor looks necrotic doesn't mean anything to me. The problem is you have a needle biopsy of a necrotic PET positive thing, and you just get necrotic tissue and you don't have a tissue diagnosis. Or you have a core needle biopsy because you want molecular testing and it's all necrotic. Doesn't help. You need to get tissue from the viable part of the tumor to get those other answers. But if it hasn't spread to lymph nodes, just take it out.
Another question online says, why would a team decide not to do surgery on a stage 3 non-small cell patient who's healthy and only offer chemo and radiation.
Right. So stage 3, probably one of the more contentious areas in non-small cell lung cancer. As most of you know, you're a sophisticated audience, there's a 3A and a 3B. 3A is ipsilateral mediastinal lymph node involvement. So it's locally advanced, technically removable, typically. All the lymph nodes that are involved are on the same side of the chest. 3B disease is a regionally advanced tumor with bilateral mediastinal involvement, or the nodes above the clavicles getting up in the neck are involved. Those are the two ways you become 3B. And that's especially the contralateral part. I can't do an operation and clear all that disease because the nodes are on both sides. So the standard of care for stage 3B disease is what's called definitive chemoradiation. So it's usually given at the same time concurrently. When we give chemo and radiation concurrently, we get a synergistic response because the chemo kills some of the cancer cells and it sensitizes other cancer cells to the effects of radiation. So you get some multiplier factor going on in the area of concern, as opposed to doing it sequentially. But 3A disease is the real area where there's contention. So the decision making in my mind is to clear the disease, does the patient need a lobectomy or a pneumonectomy? Does the whole lung need to come out or not? It's a big intergroup trial. Everyone knows what the intergroup is. It's a consortium of the NCI cooperative cancer groups that get together and do really big studies in lung cancer. And the intergroup did a study looking at stage 3A lung cancer where they compared chemoradiation to chemoradiation and surgery. So half the patients got surgery and half didn't. And if your operation involved a lobectomy, then you had a better disease-free outcome if you had chemotherapy, radiation, and surgery. If your operation involved a pneumonectomy, the outcomes were equivalent. And why is that? Because the risk of dying after a pneumonectomy is higher. So whatever advantage the patient had when we looked at a large population, more of them died as a consequence of the surgery. So at the end of 5 years, you had the same number of patients surviving. So it had to do with, again, you need a multidisciplinary team. If the surgeon's not at the table, someone's making a decision, like you asking me about chemo. It's like, I can refer you to smarter people to talk to you about chemo than me. And I would hope that my medical oncology colleagues would return the favor and make sure that they really talk to an experienced surgeon. So there's other nuances of the 3A disease. You know, you can have 3A disease with lymph nodes in multiple areas involved, high along the trachea, low along the trachea, between the two main stem bronchi. That's called multi-station 3A disease. That group doesn't do quite as well. Staging in general is a lumping mechanism. It lumps people's disease together. Individuals don't want to hear things about being lumped together. They want to hear about themselves. So when I look at a 3A patient, I say, did I find the cancer in one lymph node or in multiple lymph nodes? Did I find it in one station or multiple station? Did I look at that lymph node with my mediastinoscope and it looked like a big piece of cauliflower with tumor growing out? Or did I look like a normal lymph node and it's just the pathologist that found a little bit of tumor? So there's bulky disease, there's multi-station disease, there's microscopic disease. Those are all a little bit different. So if I have microscopic N2 disease, then I think that patient does well with aggressive therapy that includes surgery. If they have multi-station bulky disease, I don't think that patient's going to really benefit from surgery, even though viscerally they want it. It's like, can't you just take it out, doc? Yeah, I can take it out, probably, with a finite risk. But the question is me taking it out going to help you? And that's kind of where 3A disease is going.
So, kind of along those lines, when you're doing surgery, and particularly for purposes of staging, is there a certain number and location of lymph nodes that should be pulled for the most accurate staging?
Short answer is yes. So you need to look at typically at least 3 different mediastinal nodal stations. So we have a lymph node map that we use in the operating room or in the bronchoscopy suite that divides up the mediastinum, kind of an upper paratracheal, lower paratracheal, subcarinal, which is at the bifurcation of the 2 airways. Same thing on the left side. There's other nodes further down around the esophagus and something called the inferior pulmonary ligament. And on the left upper lobe, there's some special nodes that are hard to get to because the arch of the aorta gets in the way, and you have to approach those differently. And the relevant 3 stations to look at in the mediastinum vary by lobe. If the cancer's in the right upper lobe, the relevant lymph node stations are R2, R4, and 7. And if it's in the left upper lobe, it's those harder ones to get to on the other side of the aorta. So it's not the same 3 stations for each lobe. So that's important for staging. If we're doing to stage it with endobronchial ultrasound or endoscopic ultrasound or mediastinoscopy, you need to look at a couple of stations on the side of the tumor, and you need to rule out the 3B disease by looking at a station on the contralateral side, because that's a major fork in the road for treatment. Remember I said if it's contralateral, then there's much less of a role for surgery. If you define that up front, yes, everybody's disappointed, but I'm not stringing you along and raising false hope about the utility of an operation later. If it's ipsilateral, then it gets down to me to a decision about, is this a big bulky tumor? Do I think I can clear all the disease by doing a lobectomy? Or is this a big bulky tumor that needs a pneumonectomy? And I break my own rules sometimes depending on how the patient responds to treatment. So again, it's not a one-size-fits-all decision.
When you say look at the lymph node, are you talking about a biopsy or just a scan?
No, I'm talking about looking at it with my 2 eyes through a mediastinoscope or by endobronchial ultrasound where I'm looking through the wall of the airway at the node itself, and then I'm looking under the microscope. Now, I get an idea looking at the CAT scan and the PET scan, but you got to prove this. You need to prove, there's a difference between clinical staging, which is done by CT and PET and MR, and pathologic staging, which is done by getting a piece of tissue. Whether that tissue's with a needle, through an endoscope, or through mediastinoscopy, which is a minimally invasive staging technique, or you can even use VATS in a few scenarios to do staging. But, the treatment decisions are too important. And with molecular diagnosis, it's important. And we can even restage people. So we can start out with the EBUS diagnosis, give someone chemotherapy and radiation, and then use mediastinoscopy and restage them and see if it's really helped. So staging and pathologic staging is really important. And then when you do the operation, you got to take out lymph nodes too, so you really know what you've done. So it gets back to your question about VATS, or minimally invasive surgery. So the way we were all trained is a big incision between the ribs, spread the ribs. It looks like the last scene in Braveheart where you put all these big instruments in. And video-assisted thoracic surgery, which is what VATS stands for, and robotic-assisted thoracic surgery, they need to change the name because that means rats, but they need a better PR plan than rats. But these are just 2 different minimally invasive surgical platforms. And it's not quite as simple as Coca-Cola and Pepsi-Cola, but it's close. It's like I heard some endorsements of CyberKnife. CyberKnife is a company, or it's a platform to do stereotactic body radiotherapy, but you can accomplish stereotactic body radiotherapy on a bunch of other different platforms. Same thing, high doses, very few treatments. I don't know if you all get waterboarded on all of them, but so VATS was starting in the early 90s and really became much more pervasive in all of general thoracic surgery through the 90s. The ability to do anatomic lung surgery, lobectomies and segmentectomies is taken a little while. But now, if you look across the country, depends on which databases you look at, somewhere between a quarter and a half of all the lobectomies done in the U.S. are done by VATS. That's because not everyone knows how to do it. It's the same operation I did through the Braveheart incision, the same dissection, the same lymph node sampling, just accomplished with small incisions, no rib spreading. And in multiple different published studies, it's oncologically identical, if not maybe better, because it's less traumatic. And there's some issue about trauma in the immune system and how it responds. But it's certainly not inferior to the old standard operation. Shorter stay in the hospital, fewer complications, quicker return to work function, quicker onto other therapies if you need them. So it's proven time and time again to be just a better way to do it. So why wouldn't you do it that way? Usually don't do it that way because it's hard to learn. And if you're out in practice, it's hard to go back and retool. You have to shut your practice down and go somewhere and learn how to do it. So it's hard for an existing surgeon to do it. And for those of us who train surgeons, puts the burden on, the pressure on us to make sure our trainees are coming out with this skill set. Now, this brings me to the other, I'll come back to robotics in a minute. The other issue in the United States is that a great deal of general thoracic surgery is not done by people like Dr. Jablons or myself. It's done by general surgeons that have had thoracic training, or cardiac surgeons that do a little bit of thoracic surgery as well, as opposed to what I am is I'm a general thoracic surgeon. That's all I do. I don't do open heart surgery. I don't do coronary surgery. I don't do heart valve surgery. I'm trained to do it. I just don't do it. So in our training, we're trained to do adult heart surgery, baby heart surgery, and then everything else in the chest. And I'm one of the everything else in the chest guys. And there's a number of those around. But you're more likely to run into someone like that in an academic medical center or as part of a multidisciplinary cancer team. That doesn't mean that there aren't exceptions to that rule, but in general, you're more likely to run into a practitioner that's comfortable doing VATS lobectomies and VATS segmentectomies or robot-assisted surgery. At Northwestern, 90% of our stage 1 lobectomies are by VATS. 70% of all our lung cancer operations are by VATS. So, if you have, and there's four surgeons there. So if you have a team that's, comfortable doing that and can do it safely, that's the way to go. Robotic has been a slower learning curve. It's a more expensive platform. It's expensive. The robot itself is expensive. It's not going to be superior to, it'll be impossible to ever prove it's going to be superior to VATS, but it's another minimally invasive way to do it, just like CyberKnife is another SBRT platform, but there are other vendors that make SBRT platforms that get very good results as well. So I don't think robotics is an advantage to VATS. It's a little easier to learn. I personally, it bugs me not to touch the patient. So if you're having robotic surgery, your surgeon's sitting in the corner, not touching you. I have a visceral problem with that, but the data suggests that they get good outcomes. And one of my partners does it and gets good outcomes, so I'm okay with it.
So you don't feel there's any faster healing with VATS versus robotics?
No. Same size, same number of incisions. You got to get the lung out through the same hole. So it's the same.
What will you be able to do 5 years from now that you're not doing but you're looking at, and you're going to be teaching your students who are going to be working on us?
Well, if I knew that, I'd fill out my bracket and Warren Buffett would give me $1 million. $1 billion. $1 billion. $1 billion. So if you're asking me to read the future, I'm just looking 3 weeks ahead. Great question. I don't mean to put you off. I think how we integrate all of our understandings of molecular testing and then this concept of having a very specific histologic and then a molecular diagnosis prescribing a tailored treatment for that, assessing response to that, and being able to shift gears instead of like, well, we're going to give 6 cycles of this cocktail, and at the end of 6 cycles go, oh, that didn't work. Well, now we can give 2 cycles, there's fancier versions of PET scanning that may give us even more precise idea of what's going on molecularly, or rebiopsying these things and saying, yes, this is working, or no, this is not, so that we can shift gears, shift away from a futile therapy and get onto a more, I think that is going to be one of the things. I think teaching, I'm teaching my residents and fellows how to do endobronchial ultrasound, how to do navigational bronchoscopy, how to do all these less invasive ways of things that I had to learn through a maximally invasive way. There's a very important trial going on throughout the United States looking at, does everyone with a little cancer need a lobectomy? So I keep using breast cancer as the analogy, but when I was a general surgery resident, I learned one breast cancer operation. It was a modified radical mastectomy, and if you had breast cancer, that's the operation you got. Then, lo and behold, it turns out if you do a lumpectomy and radiate the breast, you get just the same, you get the equivalent outcome. We still dissected the lymph nodes in the armpit, and we still had women with big swollen arms. Now, if you do a lumpectomy, radiate the breast, and do a sentinel lymph node biopsy, you get the same outcomes. So there's a big trial going on in the United States now looking at small tumors under 2 centimeters and randomizing them to lobectomy or segmentectomy. Now, each lobe is made up of an anatomic number of segments. Right upper lobe has 3, left upper lobe has 4, both lower lobes have 5, but you can begin to take each lobe apart and take out less lung, and maybe you'll get the same outcome. This was tried back in the 1980s, 1982. It took them till 1995 to complete and publish the study, and it showed if you did segmentectomies, they had a higher recurrence rate. But those tumors were 2.5 centimeters or 3 centimeters big. Now we have CT scans, we're finding smaller ones. The thing about that trial is it's going to exclude these ground glass opacities, these BACs. So we don't use the term bronchoalveolar carcinoma anymore. Now it's been changed to a well-differentiated adenocarcinoma or minimally invasive adenocarcinoma. Doesn't matter, it's still the same disease. And it often is multifocal, so we see lots of little GGOs, ground glass opacities, GGOs. It sounds like what they're following in you. And I have a lot of people in my practice where I follow these little GGOs, which truly are less aggressive biologically. So we think of most lung cancers as having a doubling time of 300 to 500 days. So that means if you follow someone for 2 years and if it doesn't grow, it's not a lung cancer. It doesn't apply to these GGOs. It may be 700 days. They don't get solid, they just slowly get bigger. And it's unclear to us whether those are going to hurt you or not. So it's a hard decision about whether we take those out. When do we take them out? If they start to form solid pieces to them, then it starts to look like regular adenocarcinoma, and then we pull the trigger. But that's the other big conundrum, 5 years from now. Maybe we're going to be able to have a test and say that's a bad GGO, it needs to come out. That's a good GGO, you can leave it alone.
Which I had in 2003, it's been 10 years.
Yeah.
And they took out the middle one because it was attached to the top part. There was very little. Then you get them all over on the other side. So Dr. Johnson in Boston told me.
Bruce Johnson.
Bruce Johnson, yeah, he was wonderful. He said, you can't keep on taking everything out. You're not going to have lungs left.
He's right.
He says, you're ready. He says, you can't take every little thing out. So I have been monitored at Stanford here, And some of them, one or two disappeared.
Well, things that
Because
disappear, we don't have to worry about.
But they're all the same, so why would some disappear and the others? So are they lung cancer? Are they leftover from the surgery?
The ones that disappeared aren't lung cancer.
Yeah, but I mean, they look just like the others.
Right. That's the problem. That's the disconnect between looking at an image and having the tissue. So there's some new fiber optic endoscopes that are being developed that are very small. You can drive them out to the alveoli and look, and you can see the cells. Now, we don't know what some of them mean. We need to create a library that says this image means cancer or this image doesn't mean cancer, so maybe we can investigate those sort of things and say, this isn't a problem. Stop worrying about it. Right now, I worry about them. I try to let my patients let me worry about them, and they don't, because they have no symptoms. You feel fine, right?
And I had that surgery where they spread your ribs, you know, like you said. It was...
Yeah, you don't want to do that again. That was 2003. You don't need that anymore.
Dr. DeCamp, again, along the lines of what you're saying, one of the online questions, which I'm going to add just a little bit to insofar as follow-up. So not only surgical follow-up, recommendations for scans post-surgery, but if it's somebody that you are just watching and waiting, what is the...
Well, when you talk about follow-up, you're weighing the relative risk of the radiation exposure from a CAT scan and the likelihood you're going to, find out something important. And for lung cancer, for a patient with a prior lung cancer, that's the group at highest risk to get another one. Okay? So if we've proven your lung's fertile soil for lung cancer, then I feel completely validated in doing regular follow-up. My typical follow-up is every 6 months for the first 2 years. So now we've gone 700 days. We've had 4 CT scans over 700 days with nothing bad coming up. Then I go to once a year. And at 5 years, you're probably cured from that index cancer. But now I'm following you because there's a 1%, 2%, 3% per year cancer risk in the rest of your lung. So I feel justified in doing those CTs. In people who, especially younger women, where I worry about the radiation risk to their breast tissue, I might go to every other year, but it's hard for Americans to remember every other year. So I tend to have to see them at least once a year so they remember. Now, if you have higher stage disease, the follow-up is a little more frequent. And if you've had therapeutic radiation, having a CAT scan is like peeing in the ocean. It's irrelevant in terms of the additional radiation exposure if you've had therapeutic radiation. So it's just not a big concern. Radiologists all over the country, though, have been very concerned about dose. And so the average diagnostic dose for a CT scan now is a lot less than it used to be. So they've really ratcheted it down. And these low-dose spiral CT scans that we now advocate for screening is the same amount of radiation that I got flying here from Chicago today. So, I mean, we don't think about getting on an airplane and experiencing a dose of radiation, but you get, I mean, that's how much radiation you got. So I think it's a little bit of a tempest in a teapot around too much radiation.
Quick question for you over here.
Okay.
Sorry. I've been on a clinical trial for 4 years and was on a trial before then, and I've been getting CT scans every 6 weeks.
Every 6 weeks?
Yes. And so I feel like I'm walking around practically glowing. And so I'm stable. I have no evidence of disease. I'm still taking Tarceva on a daily basis. But there is that risk of potentially having problems later on caused by the scans themselves. And so we're thinking of maybe pushing it out to 12 weeks. I was 6 weeks, and then we recently moved it to 9 weeks, and now we're moving to 12 weeks. But you're talking about 6 months.
Well, I'm talking about stage 1.
Okay.
Resected patients.
Okay, yeah.
And you have to operate within the bounds of your clinical trial, too. And you sign a consent form that talks about the relative risks, of the things that are involved. And those things have to be vetted through human studies committees at your hospital and all the way up the chain of command to be, considered a valid, safe study to do. So they've weighed the relative risks. And when we create clinical trials, we have to factor in, how many tablespoons of blood we're drawing, what's the radiation exposure and the x-rays that are required. So all those things go through our institutional review boards and our human studies committees before we can offer a clinical trial. That seems like a lot of CAT scans. Are they doing your whole chest or just the nodule itself?
No, the whole chest.
Yeah. 6 weeks.
Yeah, now it's 9 weeks. We're hoping to change it to 12 weeks. But yeah, because, I have bronchioalveolar carcinoma, or whatever they call it now. Mm-hmm. And I'm doing extremely well, but, this could go on, hopefully,
let's hope
for
it does.
many, many years, but at least,
Well, it also speaks to the psychology of this, because it gets you revved up every 6 weeks. Right. I got to go have a scan. Now I'm worried about my scan. Did my scan okay? And I can tell you these ground glass lesions, it's like, is it a millimeter bigger? Is it a millimeter bigger? It's fuzzy. It's not solid.
Yeah.
So the radiologists have screens like this, where they, like boys watching the, March Madness, where they can measure things on a big screen, and I'm looking on this little computer trying to go, is that really bigger or not? I'm looking for a sort of believable macroscopic thing before I talk to you about changing gears. Mm-hmm. And those things get baked into clinical trials too. They have a radiologist and they have to make these index measurements, and they have to be the sort of final word. Is this bigger? Is it progressing or not? Sounds like yours isn't, which is great.
Yeah, very lucky.
That's good.
I have a question on the what makes it minimally invasive. So if you're doing a lobectomy, the traditional way versus minimally invasive, what's the difference in
spreading the ribs?
What's spreading the ribs? And
spreading the ribs.
And the incision is the same, or?
More or less. I mean, you're asleep, so you don't see what I do to you to get this out, but I can take out the lobe through an incision that big.
This big?
That big.
And the traditional way was how big?
Yeah. Huh. So but the other issue is you put a rib spreader in, spread the ribs apart, and that rib spreader pinches the intercostal nerves and young people get well, but it's unpleasant. And if you do this and you don't spread the ribs at all, and you're working with small instruments you get great illumination and magnification on the screen. Our kids are going to be better at this because they're good at video games. But I kid them, they got to bring a roll of quarters to keep putting it in the machine or the light goes off.
Does the instrument go in and cut and pull, or
so we use a variety of instruments, but our hands are out here outside the chest, but we're working in the chest. You do get some tactile feedback. That's the big difference between VATS and robotic. The robotic thing is really cool, and if you ever get a chance to sit at a console and play with it, because you're looking at this console and it's like going to the 3D movies. You have 3D, you got great depth when you look at it, but you have zero tactile feedback. And you put your hands and you have these articulated wrists and you can move the instruments around, but you have no feel. And so much of surgery is feel. And knowing how hard you can push and press, and I can be a little more vigorous with a young person than I can with an older person. Their tissues just aren't going to tolerate that. So, and that's the art. But it's the pain is really driven by spreading the ribs.
May I ask you, I was told why they didn't do VATS on me was because the location of it was such that they were worried that if a cancer cell escaped, it was going to get in my bloodstream. Because of where the lobe was.
But the robot
tumor
could prevent that.
No. The robot can prevent.
No.
No.
Did you have a robotic lobectomy?
No. I had a regular one, but they were hoping to do VATS, and he said once he looked at it, got in there a little bit, he saw that there was too big a risk of a cancer cell escaping and getting into the bloodstream.
Well, we have no way to detect cancer getting in the bloodstream, but the most common reason to convert a VATS approach or to just not do it is a big, bulky central tumor. Because to do a lobectomy with a big, bulky central tumor, you've got to get in there and very precisely take the vessels apart and not disturb the tumor. And it's a little harder to do that by VATS. The more you do, the Rob McKenna, who's a colleague of mine down at Cedars in LA, he's a wizard. He can do, 3A lobectomies where in my hands, I think it's safer if I do that open. But for stage 1 disease, everybody should have it. I can't imagine a stage 1 lobectomy that you shouldn't have by VATS. There's a learning curve.
So you're good at taking out the lobectomy segment, whatever, nephrectomy. So you can take it out. When are you going to be able to put something in?
Well, I do that too, but not for cancer. So I'm a lung transplant surgeon. The problem with transplantation for cancer is immune suppression. So actually, there's a whole unfortunate literature around doing lung transplants for really advanced bronchoalveolar cancers. And it was miserable because the cancers recurred in the setting of immune suppression. So for you to accept an organ from another person, we have to suppress your immune system. And that tells you the immune system plays an important role in cancer surveillance. Now, if we can, engineer lung tissue, then maybe we can. But the real issue in lung cancer is the biology. And it's not just the lobe. It's the biology of the disease, in the nodes and in the circulation. And putting something back in isn't going to help that. Usually the people can tolerate a lobectomy. They have enough lung function. A lot of you have enough lung function, I could take out your whole lung. Now, you're not going to compete in a triathlon, but you're going to live at sea level, you're going to live a normal life.
Do you see in your lifetime or afterwards using like a 3D printer to print out part of a lung or a lung and put it in? Using my tissue or someone else's tissue?
I do see that. I mean, we're already doing that in kidney and in liver, and lungs a little more difficult because of all the organs we transplant. It's the one that is connected to the outside world through the airway, where the other ones are kind of, don't have to deal with that. So we breathe in all the soot and virus and bacteria and things like that. So lung transplants are challenging because all the bad stuff happens to the actual transplant. Kidney transplants get pneumonia. Liver transplants get pneumonia. Lung transplant gets pneumonia. That's kind of a double problem. There's a question in the back.
Yeah, when my daughter was diagnosed back in 2010, it was just the beginning of the molecular testing and whatever, and the importance of tissue wasn't there when it came to people going in for biopsies or surgeons. I've sat in support groups where people have had, half their lung taken out but still don't have tissue. Do you see the fact that the importance of molecular testing kind of getting more spread and more common throughout your community? Is the attitude toward tissue getting a little bit better? I mean, my thing is tissue is gold.
Absolutely. So a couple things have happened in the last 5 years. Is number one, the folks that do the testing, whether it's done in your hospital or at another place, have gotten better at doing the testing even on paraffin-embedded archive tissue, so they can retrospectively go back and get the lobectomy if she had a lobectomy and do the testing. And a lot of hospitals like ourselves have gone to what really should happen is something called reflexive testing. Like if you do a lobectomy or you do a biopsy and it's an adenocarcinoma, I shouldn't need to call the lab and say, by the way, do EGFR, ALK, and KRAS. Just do it. So our lab does EGFR and KRAS, and if they're both negative, then they send it off for ALK, or they do their own test. And that sort of reflexive testing is what I think our patients should expect, because that means when they come back to see the oncologist a week later, the oncologist has the information he or she needs to say, this is the right way to treat this problem or not. It's a little different in early stage disease, where if I do a lobectomy for stage 1 lung cancer and you have an EGFR mutated adenocarcinoma, you put your Tarceva card in your wallet. It's a get out of jail card if it comes back, but we don't need to treat you now because there's nothing to measure. hopefully you'll never need to use that, but it is kind of psychologically reassuring to the patient that, well, if this comes back, odds are I have an easier way around this problem.
Yeah, my daughter has Ross, but it was pulling teeth to get those tests done, and it was just by accident that she was tested by Ross right at the beginning. But I just feel sorry because, now we would like to have tissue, even though we have our one card, we still would have liked to have a lot more tissue, but when she did have the biopsies and stuff, they just didn't, the
Right.
mindset wasn't there.
And for these other, lesser well-known or still investigational mutations, I think that's continues to be an issue. But in general, the level of awareness about the need to do molecular testing, very few places are going to do testing for ROS or MEC or MET or some of these other things unless they are, the MD Andersons and Memorial Sloan Ketterings that are doing next-gen sequencing on all the cancers. But I think more and more radiologists who do percutaneous biopsies, no one should have a fine needle aspirate anymore. They should all have a core needle biopsy because you won't get enough tissue in a fine needle aspirate, even though it sounds better. You need a core of tissue to do all these tests. And our radiologists now know I need to get 2 or 3 cores. And if you're going to send tissue out to Foundation Medicine or for next-gen sequencing, you need, they need like 10 unstaged slides. Well, they need a fair amount of tissue to get 10 unstaged slides. So we have to continue to educate and raise awareness. It's a very good point.
I have a question. In your practice, and as long as you've been teaching, do you see a lot of families that the same type of cancer keeps showing up? Because, for example, my cousin, who just passed away at 52, had the same cancer that I had, adenocarcinoma, and her father had it also. It's all coming from my mom's side. So have you seen a lot of that?
I see, short answer, yes. The harder answer to tease apart is because a number of the family members were heavy smokers or were smokers. So it's a little hard to tease apart the genetics from the environment. Because we know that, still 85% of lung cancers happen to smokers. Former, active, but that 15%, and that number is actually unfortunately going up, is non-smokers or minimal smokers. I had 5 cigarettes in college. That's not, you didn't smoke enough to get to any major threshold. So it's pretty hard to tease apart the family genetic piece from the environmental tobacco exposure piece. They're both important. There's a ton of people who smoke who never get lung cancer, so it's not fair. It's just the way it is.
I'm hoping whoever wrote this online, if I say this wrong, that you will let Andrea know. It's a stage 4 patient wanting to know if surgery should be considered if bacterial infections are caused by pockets or pinched areas in the lungs causing tumors. I don't know what that
Well, I'm guessing here, but I mean, if there's a central tumor that's obstructing the airway and you end up with downstream infection, but in the stage 4 setting, is surgery ever indicated? We would try very hard to come up with other ways to relieve that obstruction. Radiating that tumor to get better drainage. Talking to our interventional pulmonologist, is there a way to stent that area open to let that area drain? Because again, a radical operation is going to do 2 things. Carries the risk of the operation, and you're off chemo for a couple of months while you're recovering. And if the rate limiting step is your systemic therapy taking care of the rest of the disease and not in the lung, then I'm not sure you want to be off therapy. It's probably also not a situation where you're going to do a little VATS operation if it's really obstructing the lung. So it's a difficult situation, and it probably gets down to the details of seeing the actual scans and meeting the patient.
Another online question. Why is a 2B patient who had lobectomy, some lymph nodes, chemo and radiation, I'm assuming with no evidence of disease, not considered cured?
Well, I don't use the C word until we get out 5 years. So, you have your NED, no evidence of disease, and you're consistently NED, then we can talk about cure. Most of the things in lung cancer, as we've been around the room, the bad outcomes happen in a couple of years. And so I tell a lot of my earlier stage patients that you can have a small gathering at 2 years and a bigger party at 5, and a huge one at 10, right?
Someone online said that you'd mentioned that surgeons need to do a better job at educating primary care physicians. How does this get approached?
It's hard. Who are the gatekeepers in lung cancer? I think they're the primary care physicians who see the patients every year, who are going to need to buy into the concept of screening their patients that are at risk. If they need to have that conversation, it's really easy to order a CT scan, a screening CT scan. The problem is dealing with the results. So 98% of the little things that were detected in the CT screening group turned out not to be cancer. So just because your CT scan turns up something doesn't mean that you have cancer. It means you need to follow that patient. So we have a lung nodule clinic to try to unburden them if they don't want to do that, if that burden is difficult for them to understand. How do I counsel my patient for this 3 millimeter nodule, this 4 millimeter nodule? What do I do with that? So we can educate them. I don't think it's just thoracic surgeons, but all of medicine needs to embed the concept of screening for lung cancer, kills more people than all the other cancers we screen for added together, into their primary care practice. That doesn't mean screening, 29-year-old healthy people. It means, or the worried daughter of someone who has emphysema or a heavy tobacco exposure. We have to be able to counsel those people that screening you isn't their goal here, screening the population at risk. There's a lot of interesting research going on to try to even sweeten the spot a little bit in terms of screening, in terms of saying, okay, here are the high-risk people. We can tease out the people who are going to really have a problem. There's exhaled breath analysis. You read about the things in the news about the cancer-sniffing dogs. Well, there's some real reality to this. They're coming up with assays where you breathe on a disc and it tells you whether you're breathing out some chemicals that might say that you're at higher risk to be harboring a early lung cancer. So there's some really interesting things going on that might make screening less expensive and more and easier to do. It's the biggest problem now in the population that has a screening CT is talking people off the ledge. Just because your scan wasn't normal doesn't mean you have cancer. You had some little nodules that we need to follow. It just becomes part of your health maintenance.
I love the idea that you said that primary physician should be your gatekeeper, because I belong to an HMO, Kaiser, and they had this rule that if you had a cough for so long, you automatically got a X-ray and a CT scan, because my doctor said she would have never sent me down there because she couldn't hear anything. So she missed the spot. She dropped the ball, but since Kaiser had that in place, they found the cancer, saved my life.
And that's a way that some physicians who are proactive have gotten around the screening thing, is if you have a symptom, then it's not a screening test. You're ordering the CAT scan because of this persistent symptom. That's not a screen. Right. If you cough up blood, you're not getting a screening CT scan. You're getting a scan to understand why you coughed up blood. If you have a recurrent pneumonia, you're getting a scan for that reason. And then it gets paid for. But it just walking in the door saying, I want it, like when you turn 50 and you get the little AARP card in the mail, and then your primary care says you need to have a colonoscopy. We need that sort of mentality to start happening for not everyone, just the smokers. Just the population that we know is at risk.
But I'm not a smoker.
I know, it's not fair for you. But if you have a cough, then
But everybody I'm meeting that has cancer now, I'm not at grocery store, vitamin store, none of them have been smokers, so there's a lot of us around.
there are. And, yeah. And that's yeah. But that's good and hard to deal with because, that number I said is 15% of the population that gets cancer aren't smokers. It's probably creeping up towards 20. But it's also unclear why 2/3 of them are women. Is there a gender issue here? We don't understand that. It's perplexing.
Maybe more women go to the doctor than men. Could it be too?
They do.
I was told by someone that it's a good idea to do chemo before you get surgery or after you get surgery. See, I didn't get that. Then your chances of seeing all these spots that I saw 2-3 years later, different, some
So,
one way, some the other.
Upfront chemo versus outback chemo.
I had stage 1.
So for stage 1, there's no data that giving upfront chemo is beneficial.
Before surgery
There's no data.
or after.
Well, for big stage 1s, there's some data. If you have a tumor greater than 4 centimeters in size, there's some data that chemotherapy following that helps. Stage 3 is completely the opposite. That it's pretty clear that surgery up front in stage 3 is a bad idea. Now, the other practical thing is that it's easier for us to get people who've had chemo through surgery than to give chemo after surgery. And we look at study after study after study of trying to deliver chemotherapy after a sizable operation, either the prescribed amount of chemo isn't delivered or the number of cycles is shorter. So that's not peculiar to lung cancer. That's true of colon cancer, stomach cancer. It's harder to give chemo after a big operation. It's harder for patients to tolerate it. It's easier for us as surgeons to nurse you through an operation after chemo. But there's no data yet that it's beneficial in stage 1.
Before surgery, it's not beneficial either, before the surgery.
That's what I'm talking about,
Yeah,
before surgery. There's
or
no evidence of this. I think now that with endobronchial ultrasound and our ability to detect stage 2 disease prior to surgery, my prediction is that we will move towards giving chemo prior to surgery for stage 2 disease.
But not
And maybe 10 years from now, we'll give it before stage 1. But remember, if 80% of the stage 1s are cured, why am I giving you chemo? I'm going to treat 10 people for only 2 really need it.
I was cured for 2 years, but then little spots started all over.
And the question I would ask then is that the cancer came back, or is that a new cancer?
I don't know.
I don't either.
Nobody knows because
No one knows.
they're not large enough to biopsy. And I went everywhere. I went to Sloan Kettering.
Well, how do they find out it was cancer? They take it out?
They don't know for sure.
Right, I know.
But they say they're so small that, and only Sloan Kettering, they said, we're the best in the world, they told me. We could do a biopsy. and they did a biopsy of one of them on the right side. And I thought they would do it under a CT scanner. They did it under an X-ray. And I was all drugged up, and I said, oh, but aren't you going to do the biopsy under a CT scanner? She said, all our CT scanners are busy. This is the best I could do. I said, you're not going to find it then because it's too small.
Right.
And everybody, I went all over the country. I've seen everybody. And then they said, after it was over, she tells me, well, you were right. We didn't find it. We couldn't hit it. We couldn't hit it because it was too small.
Yeah.
And that's
Small.
what happened at Sloan Kettering.
Small is good.
So I never go there again. I went to see Dr. Bruce Johnson instead, and he said, who told you to do that? He said, why did you do that? I said,
Neil has a question.
Yeah.
We know Sloan Kettering is not the best. Northwestern is. That's the best. Right. Right. At least for tonight, until we all go to Stanford or Davis or wherever. Can you? And I said Davis also. Can you talk about any clinical trials that you and your fellows are doing that would be interesting to us as far as pushing the envelope of thoracic surgery further along the way?
Well, the most important trial going on right now, in my opinion, is this intergroup trial that started not at Memorial but at Cornell, across the street. Nasser El-Turki is the surgeon that's running it, and it's now open. It's kind of an interesting trial because it's now U.S., Canada, and Australia have signed on to it too, and it's going to have more than 1,000 patients, and they're 80% done with this trial. We're going to randomize, as I told you, intraoperatively to lobectomy versus segmentectomy, because I think that'll be a game changer for small tumors. If we're going to screen people, we're going to find small cancers, and the battleground in lung cancer, in my prediction for the future, is around the 1 centimeter nodule. Not the big cancer, but the little peripheral cancer. So that's the biggest phase 3 ongoing trial right now. I think there will continue to be interest if we find that smaller and smaller operations are just as effective. Eventually, our radiation oncology buddies are going to say, but if a small operation's okay, why don't we just ablate that? And that's what CyberKnife for stereotactic body radiosurgery is. It's an ablative dose of cancer to the little nodule. But we're a ways away from that, because we haven't even proven that the smaller surgery is effective. But we're also learning that, cancer in general is a systemic disease. So the people that I can get and cure in stage 1, great. But we're going to be able to identify the high-risk stage 1 people and know who should have targeted therapy, who should have regular chemotherapy, as we try to bring multidisciplinary care to earlier and early stage. Right now, in our hospital, the stage 1s don't even go see the medical oncologists unless they're big, unless they're greater than 4 centimeters, because there's no data about giving them additional therapy. So I do their follow-up. As soon as they're bigger or they have nodes involved, then we involve the medical oncologist and we see them together. And if they're stage 3, they see all 3 of us.
So somebody online wants to know if you perform talc procedures, and can you differentiate or let them know the difference between talc pleurodesis and thoracoscopic VATS talc pleurodesis? When would you perform one over the other?
So the question has to do with recurrent pleural effusions, especially malignant pleural effusions. And this is an area that surgeons have been involved with for a long time to relieve the recurrent bouts of shortness of breath related to fluid building up in the chest. So a number of drugs have been, basically pleurodesis, there's a layer of pleura that forms the skin on the outside of the lung, and there's another layer of pleura on the inside of the ribs. And if you pleurodesis, you stick those two things together and glue them together with some kind of medication. And usually the medication is pretty much designed to just create a lot of inflammation. And if you get inflammation, you get scarring, and then those two layers of pleura are fused, and then there's no place for the fluid to accumulate. So that's the concept. So yes, I do talc pleurodesis. You can do talc pleurodesis by just putting in a drain, draining out the fluid, and then putting talc in through that small drain and having the patient change positions, kind of like shake and bake chicken, trying to coat all the surfaces. That works okay if the lung expands and you already have a diagnosis and you know what you're treating. So if I know the patient has metastatic breast cancer, we don't need additional tissue, we don't need other things to do testing, and I can drain the pleura and I can get it to expand, because it only works if the two layers of pleura touch each other, then I think it's fine. You can put talc in any way you want. But everybody here knows talc is a powder. It doesn't go into solution. So you have to put it in a 50 cc syringe and shake it up real good and squirt it in and get the patient to move around. When I do it with VATS or small incisions, I can look in the chest, I can drain the fluid. If there's multiple pockets of fluid, I can break up those pockets and get all the fluid. I can have my anesthesiologist forcefully inflate the lung and make sure it recruits, and I'm going to have those two layers of pleura touch each other. And then I have the advantage in the OR where I can blow it in as a powder, and I can see that I've dispersed it well. Now, we've done a large a 300 or 400 patient trial in the CALGB in the past, and they've shown that the VATS group's a little more effective, but at 30 to 60 days, the outcomes were about the same. So in that randomized trial to bedside versus in the operating room, it didn't seem to matter. So I think, to me, it comes down to the individual decision. Do you need more tissue? Does the effusion look complicated? And in the patients where it doesn't expand, we do have another option of putting in what's called a tunneled pleural catheter, so that we can leave a drain in the chest where we can drain the fluid without having to stick a needle in the patient. And probably a half or 2/3 of those people, after about a month of that, they'll go home with this, drain themselves a couple times a week. That fluid can dry up on its own, and they get what's called an autopleurodesis. But talc in the hospital in an acute setting has been probably the most effective agent. People used to use tetracycline, and now there's no tetracycline, so we use doxycycline. Talc seems to work a little better than that. There's a chemotherapy drug called bleomycin, but it's 800 times as expensive as using talc. Talc's like $4 a dose.
Word that keeps coming up, and I'm not hearing it well. But is it VATS? VATS?
Yes, ma'am. VATS.
And what is that?
Video-assisted thoracic surgery.
Thank you.
There's a couple more questions that I didn't get to on time, from online, but we're running out of time. So I want to do some of the housekeeping things that we do and close the meeting. I want to first start by thanking Dr. DeCamp. It's a really important meeting, and I think everybody asked some really great questions. So it's going to be good stuff for us to push out moving forward. I actually want to give a shout out to Karen Gorenberg. I hope she's online tonight. She's one of the patients that is close with the foundation in Florida, and she just held her 5th annual Run Amok with the Duck 5K run. She's been doing it for us, for 5 years now, and she raised a little over $50,000, so she's really deserves a big, huge thank you and a big round of applause. The upcoming living room. Next month, I want everyone to note we are going to move out 1 week. So it's April 22nd. I'll get you guys all the new calendars because we have finished the living room calendar through the year. So I have all of what's coming next. I'll push that out to you. But next month, just FYI, it's April 22nd. It's actually Marty Tannenbaum's coming from Cancer Commons to talk about DYD and donating your data and sort of the big data concept and what that is all going to mean now and moving forward in the future. May is Deborah Morosini from Foundation Medicine. She's coming out to talk a little bit about pathology and some next-gen sequencing and what that looks like now and in the future. And then, like I said, I'll give you the calendars moving forward after that. Our next run is in Ohio. I don't have my glasses on. They're on my head, right? Do this all the time, and I'm squint and I'm pulling back. We have a run in Ohio this weekend, just some of our next events. So if anybody online's in the Columbus, Ohio area, please check us out. It's on Sunday, March 23rd. Chicago's coming up. Yes, Sunday, April 13th. So all of our Chicago friends, please come out and join us there. You'll see Dr. DeCamp and all of us. Hopefully
the winter will be over.
Yeah. It's still going to be cold, no doubt. And then Dallas, Saturday, May 3rd. So if you're in the Dallas area, please reach out for that. 2 of our local events coming up, or one is our golf tournament, June 9th. So anybody who's interested in that, please see Andrea after the fact. One of the things, again, that you guys know I hate to do, but I have to, is let you know when things have gone, I don't even know what I'm trying to say here. We've lost 3 people since the last living room. And I hate, it's always such an uncomfortable thing for me to have to tell you guys, so it always makes me feel like, Bill Callanan, who was 51, he only came to a couple of meetings, he and his wife Ruth, he's got 2 very small children. He passed away a few weeks ago. Carrie Peterson, who I know all of you know, she passed away a little over a week ago. Anna, who some of you came out to San Francisco for Team Anna. She was there, and she was celebrating her 37th birthday, I think, at our run last year. She also lost her battle. So I just want us all to keep them and their families in our thoughts and prayers. Carrie service is Friday, so if anybody's interested in going, I'll have information after the meeting. Big thank yous, obviously, to everybody in the room, everyone online. Thank you all so much. We couldn't do this without you here. We couldn't do this without all of you watching. Huge thank you to Genentech for their continued support. We really couldn't do this without them. Thank you to Penn TV, obviously. I really want to take time out again. I don't think I thank staff enough for being here and all the help that they give me. Andrea and Danny and Jen are here at every meeting, helping me with sort of the back end of what we're doing. Andrea's moderating online. She's the one online chatting with you guys all the time. And of course, the Office Bar and Grill for all the good food. So thank you, thank you, thank you. And I will see you guys next month.
And thank you, Carrie Peterson's family, because she got so much out of this fabulous group. And just want to thank you all.